My name is Daniela, Alves. I'm a clinical psychologist, and at the moment I work with the bariatric team at the Pre-Operative Hospital. I was working at the Homerton in the bariatric team last year. Yes, I'm happy to be here today. And with me I have Chinar, is our in-house IAP therapist. It's quite interesting that the two presentations that we had before were highlighting the role that our patients have in understanding what is happening to them and how we, as health professionals, can create opportunities for them to acknowledge what is happening to their lives, what are their expectations and their goals in regards to bariatric surgery. So, to create the opportunity to offer that support to our patients, to know more about them, we created this collaboration at St Mary's Hospital. So we have two IAP therapists, working with us from the Back on Track Hammersmith talking therapy team. And this not only, and I will explain in more detail, but in general, this not only allows us to offer more psychological support to our patients in preparation for bariatric surgery, but also gives them more opportunities to think about their process, to think about bariatric surgery, to think, why am I doing this? To reflect with our therapists in clinic, they offer 4 to 12 sessions, to reflect about what is happening, why am I going forward with bariatric surgery at this stage. What we usually tell them is it's not only a yes or no for surgery. It's about thinking with them and helping them thinking when is the right timing to go ahead with bariatric surgery. Another thing that we also say, that we also discuss with them, is that we usually tell them, our surgeons, they will operate on your body, but that body has a story, you have a story, and we will be in a much better position of helping you, of knowing exactly what we want to achieve with bariatric surgery if you know your story, if you know you. For that reason, again, we created this protocol, this collaboration between improving access to psychological therapies IAP team at Back on Track and the bariatric liaison psychiatry team at St Mary's Hospital. So we have quite a long list of acknowledgements because different minds were together thinking about this collaboration from the Imperial Weight Center and also Back on Track Hammersmith and Fulham IAP team. So as I was saying, this collaboration was developed to meet unmet needs in psychological support within the Imperial Weight Center in both Tier 3 and Tier 4 pathways. I'm the clinical psychologist involved in both pathways at the Imperial Weight Center. And one of the things we do is to make sure that we explain in the contact that we have with our patients, we offer them enough support for them to understand the continuum between both pathways. And our IAP therapists working with us will see patients, as I will explain in a minute, in both pathways as well. So, meet unmet needs in Tier 3 and Tier 4 pathways, subclinical concerns. We see several patients with disordered eating or what we call emotion-driven eating, using food as a coping mechanism to deal with their emotions. Body image, anxiety and mood concerns. So those we would say are the main areas of support. We also, obviously with this collaboration, wanted to increase therapy resources pre and post-operative and clinic capacity, and promoting more psychological resources for positive post-operative adjustment. We keep saying to our patients that the outcomes that we want to help them achieving after bariatric surgery are not only focused on weight loss, but also quality of life. And one of the things we do at Arkuter is to work, we are developing different resources now to get to know our patients and to work with their values. We are developing resources with acceptance and commitment therapy, focus on patients' values, knowing more about them. The more we know them, we definitely are in a much better position of helping them. And also, one of the goals with this collaboration is to meet an unmet need in IAP, offering them, the IAP therapists and the IAP team, the talking therapy team, increasing access to psychological therapy for patients with long-term conditions where depression and anxiety is impacting on management of their condition, and also better integration of IAP set care model within the bariatric care pathway. We have 2 IAP therapists working with us, and they accept patients with different levels of complexity. So we, the psychology and psychiatry team, will assess all of those patients, and based on their clinical needs and their complexity, we will then refer them to our high-intensity CBT psychotherapist or to our psychological well-being practitioner, depending on patient's complexity.
I'll just add with this, with the unmet need in IAP, so the integration of the step care model was part of the NHS 5-year plan, so really increasing access for support for people with mental health difficulties, but also focusing on their health conditions. So this has been one of the reasons why this project has come about, and also part of it is actually reducing access, reducing health seeking as well. So we're just kind of making the pathway a lot clearer for people, making sure they are getting the support when they need it, but also not getting support when it isn't necessarily due.
Yes, because the timing of support is also important. We had, even when I was working here at the Homerton, was the same. We were definitely assessing patients and knowing more about their needs and referring them, signposting them when needed. But having the AF therapists working with us inside the house, and we offer supervision to them. So and another thing, for example, they can also have access to work in an MDT, specialty setting. So for them, it's also a very good opportunity, career opportunity to work in an MDT context. So let me just give you an overview, a very general overview of our pathways in Tier 3 and Tier 4, and why and how our IAP therapists end up receiving the referrals. In Tier 3, all of the patients have an initial medical and dietetic appointment, and they complete an initial psychological screening questionnaire. That information then is taken to MDT, so all the cases are discussed on MDT, and based on the information from the appointments and the information in the questionnaire, some of those patients are offered a one-to-one psychology or psychiatry review, again, based on their complexity. From that review, some of the patients will then be referred to one of our IAP therapists. If, for example, I see the majority of the patients, I'm the clinical psychologist in Tier 3, I see 99% of those patients in one-to-one. If I see that, for example, they present with frequent patterns of emotion-driven eating, or if they present with significant anxiety and low mood related to their body image apprehension, that could be one of the referrals that I could send, for example, for Chinar as a high-intensity CBT therapist to work with them to offer cognitive behavior therapy up to 12 sessions. In Tier 4, we have the pre-operative and the post-operative pathway. In the pre-operative pathway, all of the patients, the first contact with the psychology team is in a psychology workshop. They will also complete a questionnaire. We will triage that questionnaire. Some of those patients, based on their difficulties, will also be offered a one-to-one with the psychology or psychiatry team. After that, we will also decide if they would benefit from support from our IAP therapist. So the message is that everyone will first have a one-to-one appointment with a psychology or psychiatry team, and then from that appointment we have the referrals to our IAP therapist. So everyone will see the psychology team or psychiatry team first. We need to triage accordingly because we also need to take into account patients' complexity before referring them to the people with high-intensity therapists. In the post-operative pathway, we might have referrals to the bariatric psychology or psychiatry team from different disciplines, our bariatric nurses, they are here, some of them, and bariatric dietitians. They might send a post-operative case or refer to our team. We will see them in one-to-one as well, psychology or psychiatry, and then we might refer them to our IAP therapists. So the message is that our therapists are seeing patients in both pathways, and in the Tier 4 pathway, bariatric surgery, both pre-operatively or post-operatively. We'll give you more information about the areas that they cover in both pathways. So patients referred, this is a summary of what we said in the previous slide, referred after the initial assessment with the bariatric psychology or psychiatry team, and our referrals are screened to assess the suitability. The inclusion criteria that we have to send patients to our IAP therapists, pre- and post-bariatric surgery patients under the care of the Alves Weight Center, mild to moderate anxiety or depression, emotion-driven eating, and we have inventories to assess emotion-driven eating as well when they are eating in response to emotions, to difficult emotions. Sub-threshold for an eating disorder service, for example, subclinical needs in an eating disorder, they might also see them to offer cognitive behavioral therapy, and low-risk patients. Exclusion criteria, patients with more serious mental health conditions, substance misuse, and signposting to specialist services, secondary care, trauma, patients with PTSD, or if they meet criteria for an eating disorder. For example, in the one-to-one appointment with a psychology or psychiatry team, one of the things that we will assess is if they meet criteria for an eating disorder. If that is the case, we will, instead of sending to our therapists, we would signposting them to a local eating disorder service. Usually we send them, we do that, sending a referral to a single point of access, West London or CNWL, and then they will triage and they will send the patient to an eating disorder service.
So with the complex mental health problems, I do a bit of consultation with the clinical psychologist or the psychiatrist who are making referrals. It's more even having discussions that if there is a complex mental health difficulty there, is it actually suitable to work within the IAP concept as well? And are they stable? So I have had clients referred to me who are bipolar and are stable, they haven't had the occurrence of their difficulties.
Subthreshold trauma.
Yeah, trauma, so I come up with some level of trauma as well, but it's looking at whether they do fit into the IAP context and if they are stable enough for me to work with.
Yes, because it's much more, it's a comprehensive assessment that we, the psychology and psychiatry team, need to guarantee before those patients are sent to Chinar or the SARA, our PWP. Because it's not only about diagnosis, it's about symptoms management as well, so we need to liaise with their local mental health teams also to know more about how they are managing their symptoms. So, Chinar, if you can explain more about the support.
So within an IAP team, we generally work within a step care model. So for those of you who don't really know about IAP, there are certain needs in which we work with. So step 2 is generally with a psychological wellbeing practitioner, and these are normally the referrals after a GP has seen someone. This is primary care involvement. Generally these are sort of very mild to moderate symptoms of depression and anxiety in an IAP concept. Within the bariatric team, we've applied that approach to this, and we've tailored the interventions that the PWPs, so psychological wellbeing practitioners, are trained to do within the bariatric team. So at step 2, our psychological wellbeing practitioners, they deliver guided self-help CBT. So this is more structured, it's very time limited, they are half-an-hour sessions. They're limited to 4 to 6 sessions of treatment. Generally this is weekly, however our practitioner who a lot of the data has come from, she was doing the sessions every 2 weeks, so it can be blended. It gives a bit of an opportunity for comprehension of the information they've been given and to really put the intervention into practice. That can also be blended either for telephone work or face-to-face, and again that's a very similar format in IAP, that's what we do. 4 to 6 sessions, half an hour. Treatment areas, so as we said within the care pathway, this is either going to be pre-op or post-op. Depending on the difficulty, mostly focusing on emotion-driven eating. We do focus on anxiety, low mood, and I also mentioned sleep. So sleep difficulties, we do quite a bit of work around sleep hygiene. Within step 2, I also cover it in step 3 as well. So within step 3, so again this is the same as what we do in IAPT. So this is high-intensity cognitive behavioural therapy. I deliver a few modalities around CBT, so mostly cognitive behavioural therapy, acceptance and commitment therapy, and I do a little bit of work around compassion-focused therapy, which is CFT. I go up to 12 sessions. This can depend on the presentation I'm working with. So some clients don't always need 12 sessions, some might 10. If I'm working with trauma, I might need to go up, but it's really dependent. General guidelines are 12 sessions. These are 15 minutes long. They are usually done face-to-face, however I can do a blended approach. I have some clients who are on my waiting list who are actually wanting to come from, I believe, Dorset or Bournemouth to see me, so we're kind of working in a way where if transport isn't available, we will work over the phone, and I've also got some clients that based on their health difficulties, they can't always come to me. And in particular, I've got a client who comes to me from Hertfordshire, so to St Mary's Hospital, Paddington. So I try to be as flexible as possible to make sure that their needs are met. My treatment areas are quite broad. Again, pre and post-op. I work with subclinical trauma, so although I do work with post-traumatic stress disorder within IAPT, within this particular presentation, it has to be somewhat related to their, I suppose, to the difficulties around their health, so health and weight loss. So there might be some issues around body image relating to their weight and how they feel. In most cases, as mentioned in one of the earlier presentations, this clinical population do experience a lot of trauma, childhood sexual abuse, domestic violence, low self-esteem, and some of those aspects come through in the trauma. So I kind of have to be mindful about how I'm approaching it and whether it is directly related to their weight loss and weight gain. There's lots of work around body image, some elements of body dysmorphia, particularly in changing, so that adjustment post-surgery, and also the expectations of what their body is going to look like after. There's a lot of worries about, am I going to have excess skin? Am I going to look very differently? Is my physical health conditions going to be better? So bearing that in mind, lots of work around emotional eating and anxiety around weight, and just general anxiety and depression that might result from this. It's quite a mixed bag, but there's a lot of scope for work here. Which I also need to work out.
It's important to mention that both higher therapists have supervision with our psychology team on a weekly basis. So obviously we discuss the level of complexity of those patients, how they are feeling as therapists by working with that patient, if they feel that they can meet the patient's expectations and consider their level of complexity. We definitely have in this population several patients presenting with history of sexual abuse, and even, for example, when they lose weight or their relationship with their bodies in terms of weight gain, using their weight as a shield for protection, and they have histories of sexual abuse, and how that might change, might affect their post-operative adjustment. This is about giving them, with the therapy, with our therapists, if we feel that the level of complexity, if they are suitable for their clinic, giving them more time and in a safe space, a safe therapy space to reflect about this, to see how the dynamics between the previous experience in their lives, involved, for example, sexual, and now their post-operative adjustment, the new chapter that they usually open after bariatric surgery.
There can often be a re-emergence of trauma as well. I haven't mentioned it pre-operatively. As the weight starts to come off, that trauma can re-emerge, particularly they're now getting new attention that they have previously got because of how their body looks. So some of my work could be focused around that trauma PTSD presentation.
We also have peer supervision meetings with our psychiatry team, and if we have more complex cases, we also address those cases there. But we need to guarantee that, for example, in supervision on a weekly basis, we offer our therapists enough time and enough space to address more complex cases and how they are feeling with their work with them. So we will now give you some outcome data from our 12-month pilot study with our the other psychological practitioner that was working with us for a year, and we have some outcome data on patients' clinical progress before and after her intervention. The measures that we were using in that pilot study were the Dutch Eating Behavior Questionnaire, the DEBQ, to address emotional eating, so focus on patients' relationship with food. This is an important instrument for us to also consider what is the type of intervention we will offer. General anxiety disorder, that's 7 for anxiety, PHQ-9 for depression and mood. Client service received inventory. One of the things we want to assess is if the intervention, the support that they receive from our IR therapists will also have access in healthcare utilization. If the number of appointments that they need to attend after bariatric surgery reduces, or if there is any impact based on the support that they have and how much appointments they need to attend. And LTC specific questionnaires, for example, diabetes distress scale, brief pain inventory, consider that diabetes and pain are the potential areas that we very often in our patients. And also psychology qualitative feedback, patients experience questionnaire at the end of the treatment to know how they felt, to learn from them how did they feel with the treatment.
These last two measures, the CSRI and the disorder-specific measures for health conditions, these are part of the national pilot, particularly in London, to see if our input with health services is beneficial in kind of integrating between mental health and health conditions. So there are quite a few services around London who have been using these disorder-specific measures in the sort of last 12 months of the pilot. So we should see if this does work and if it does benefit this particular group. Okay, so just a bit of an explanation of the outcomes. So at the time when we were collecting this data, I wasn't working with the service, so we've got limited, somewhat limited results, but it's actually still quite a good number of clients that our colleague Louise saw when she started So Louis saw 39 clients
Yes,
which had completed treatment here.
Yeah, these are the numbers only for the first year. We are continuing the collaboration, so we'll have more and more data in the future. This is just for the first year.
Okay. So one thing we said that there were some changes in their outcomes during the treatment. So in terms of mean scores for symptoms of depression, so most clients started off around what we classify as mild to moderate symptoms of depression. This decreased by sort of 4.69, which then kind of brings them to what we call recovery rates for symptoms of depression. So very mild symptoms of depression, which is generally what we look for in IAT when we're not offering treatment. There's also a reduction of symptoms of anxiety, so the GAD score, so that's gone from mild to 9.79, to a reduction of what we deem as being in recovery, so change of 3.69. The Working Social Adjustment Scale, the WAS, is something that we use that looks at overall impact of their mental health difficulties on their mood. So it covers work, relationships, social leisure, private leisure, and also home life. With that as well, that's kind of a mild score in terms of the impact, and that was also reduced. With the CSRI, so we noticed that there was a reduction in medical appointments attended. You might notice a bit of a discrepancy in numbers. With this clinical population, it's a bit difficult sometimes to make sure that they are obtaining their appointments. So there was a little bit of talk out there, but there was a reduction by 1.5 appointments. In terms of the DPBQ scores, again, there was a reduction there, not perhaps a significant reduction, but it's still starting to look for someone having a step to intervention and improving their attitudes towards their health and eating behaviours. So with the population that we saw, those who did have treatment, so 4 to 6 sessions, they were all pre-op, they were in tier 3, and 35% of that cohort that we saw were then considered as being ready for surgery. So they were effectively green-lighted, weren't they, for surgery? So actually that's quite substantial, I think, for clients who previously maybe wouldn't have been psychologically ready for the changes that come from surgery. So there's a fair number of them is actually ready to actually have their surgery. So there's quite good outcomes. And if you think about longer term, if we keep offering this, how many more patients are actually going to benefit from having psychological support pre or post-op to actually maintain their so to maintain weight loss before surgery, but also to maintain the changes post-surgery. Now, this part here about cost savings, so the CSRI that I was talking about previously, part of that is we're looking at cost saving, but it's also looking at reduction of healthcare utilisation. In this particular project, this particular part of the data that we received, there was a cost saving of £100.38 per patient. Doesn't seem like a lot, however, if you think about longer term, that's actually quite a bit of cost saving with clients accessing support. And long term, I suppose we're looking to see if this is something that we can continue on to see whether clients are able to remain stable post-surgery and also perhaps to minimise weight gain after surgery, and minimise weight gain before they have surgery as well. So I suppose it's quite an important thing that we're doing here with these particular client groups.
Yes, and these patients obviously will offer 4 to 6 sessions. We also want to see the impact of the longer intervention that they are now being offered with our the CBT psychotherapists. So we'll have more data in the future.
So just a bit of feedback. So quantitatively, we usually tend to gain feedback from clients after surgery. So this is their patient experience questionnaires. These are just 2. So for one particular client, it was helpful for them to do work over the phone because of flexibility with work. So in a way, for them, they said visually it was helpful. It was quite useful for them to see that it could be so helpful in their journey. And some clients, for this particular client, worked for them in right way. So we do practice a bit of mindfulness within our treatment, so help them put everything into place. And mindfulness does come into place when we do work around emotional eating. It's something that we continue to use, and nothing would have changed. So it's quite nice feedback to get from our clients.
We are definitely moving in the direction of third wave CBT techniques with mindfulness and ACT, and our therapists not only we, clinical psychology, for example, in my work in Tier 3, we are definitely developing more resource-oriented third wave CBT, and our therapists are definitely integrating more of that in their work with patients, and also having training in therapy modalities such as ACT, sequence and clinical therapy, to offer that support. Yes, we can. This is just a summary of what we said, and again to highlight that we have some evidence now in different studies pointing out how effective modalities such as acceptance and commitment therapy can be in working with patients with frequent patterns of emotion-driven eating and body image difficulties. That's why we are obviously offering more of that support at Imperial.
So here's just a quick case example of a step 2 client. So this client was pre-op, and there were quite a few long-term health conditions. So often with the clients that I see, and also with the clients that my step 2 colleagues will see, so there are a lot of health difficulties. Type 2 diabetes is very common, osteoarthritis, high blood pressure, recent cancer diagnosis for this particular client. So Louise offered a combination of face-to-face and telephone appointments for them. In this approach, she did the sessions every 2 weeks, and part of the using the measures for the CSRI, we have to do those measures at 3-month review. So I suppose it's a good way to keep in check with the client to see if they are maintaining their progress. So as an overview, generally what psychological wellbeing practitioners do, the same with myself, we would always introduce them to the cognitive behavioural therapy model to begin with, as a way of helping them to understand and map out their emotional driven eating. And in this particular case, we use a Fairbairn model for binge eating. I think it fits quite nicely, particularly with this presentation. So we're looking at really establishing a regular eating pattern, because that can be quite a challenge when you have disordered eating. Typically, if someone's feeling quite low, and also to help to establish an eating pattern, we might use behavioural activation, which is a method where we're looking at values, we're looking at what is important to the client, and actually mapping out specific times in which they would do that in the hope that it would improve their mood. So lifting the depression as well. Mindful eating, and we normally end on relapse prevention. So with this particular client, they recovered on the PHQ-9, so that's symptoms for depression, and they also, so there's also moderate depression, also repeating these clients in the IAPT models being recovered. However, they maintain subclinical GAD-7, which is not necessarily a bad thing. We're looking at a downward trend in terms of symptoms of anxiety or depression. And I would imagine that with a presentation like this, the work that the client is doing, in the way that CBT works, that we would imagine that continuous practice, those scores for anxiety will keep going down in progress.
I don't know if we have time or if you want to, even though we don't have outcome data for your intervention tonight, is there any case that you would like? We were talking in supervision about, for example, support for weight regain after bariatric surgery.
Yeah, I can give you examples. So I'm currently working with a client who is post-op on her second bariatric surgery. The first surgery wasn't successful, and she gained quite a substantial amount of weight after the surgery. I think she's actually weighed more at her pre-op weight after the first surgery. So she's come back, she's had revisional surgery, and one thing that we highlighted with her is there is a lot of emotion-driven eating relating to chronic pain. She has a number of health conditions as well. One thing we're finding as I've been finding as I've been assessing her is that there is a history of childhood sexual abuse, which is relating to perhaps the trauma and how she feels about her body. We've also done a little bit of work on establishing that her eating pattern is coming up, so wanting to eat more and eating the wrong sorts of foods is coming up as post-op complications. So this particular case, I'm looking at lifting, kind of helping her to establish more of an regular eating pattern without too much of the post-op dietitians. Referring her back to dietitians, she's struggling to make sure she gets nutrients. She's been referred back to the surgeon to investigate the post-op complications. There's a lot of vomiting, there's a lot of other gastrointestinal problems that are coming out as a result, which is then driving her to want to eat a little bit more. But most of our focus is coming back to the emotion-driven eating. She's getting a sense of not feeling satisfied after eating. It's not because her stomach isn't full, it's that sense of I'm not eating the foods like I used to eat. So there's a lot of changes and adjustment work that we need to be doing. So my treatment plan with her is very much going to be around looking at the patterns of emotion-driven eating, helping to establish a routine, really helping her to focus on her values and what's important to her. Because now that the surgery plan is on again, she's, I suppose, having to kind of relearn what she wants to get out of life, and now that she's losing some weight, how can she start to do things that make her feel good as a way of like helping with emotional releasing. I'm also doing quite a work with sleep hygiene as well. So just to give you a little bit of a flavour of perhaps what a client might look like that I work with, and how I might implement treatment to that. And I'm looking at doing 12 sessions with that. I'm not really going to be touching on the childhood trauma because it's not necessary at this point. However, if she does sort of lose a substantial amount of weight, there's a possibility that we might need to do something like that.
Yes, yes, just a final word that obviously we need to triage all of the patients. One of the things is to check patients on video to have access to their medical records to be sure that when we send patients to our IAP therapists, they are be taken to another level of complexity. And if, for example, patients don't engage in treatment with them or DNA, or that information will also be important for MDT in terms of compliance, in terms of patients' readiness to go ahead with bariatric surgery.
And it's also, we've highlighted a few clients who actually were not suitable for treatment just through being offered treatment with me, just because of their lack of engagement and lack of readiness to change.
There's a meaning about the lack of engagement, and that can be indicated that something needs to be assessed. Thank you very much. Thank you.
Yeah, fascinating. I suppose the question is it, how has this been organised? Because presumably you're paid by the mental health trust.
Which is, we work together with your part.
Yes.
You're
West London.
You're with Imperial.
Imperial in West London, but it's West London that is.
And how come West London is treating patients from Dorset?
Because they are part of the bariatric service.
They are national service.
So have you had a buy-in from your local psychiatric provider into the bariatric service?
Because it's part of the collaboration to have access to patients through the
It's quite a complex.
Yes.
How many patients do you see?
Sorry?
How many patients do you see sort of weekly? How many of you are there?
It's our IAP therapist, it's a psychologist or psychiatrist.
A bit of sort of quick summary of.
So our IAP therapists, they can see how many treatments our PWP can do, up to 6 treatments per week, because it's a part-time collaboration, so they have 2 days a week with us.
And I see 3, as I've only got clinic. Because clinic space is very flat, so I've only got clinic on Monday morning, so 3 clients.
Yes, we are trying to manage the resources the best we can, but definitely making sure that the patients that need that support, cognitive behavior therapy, and that we in clinic, psychologists and psychiatrists, feel that they would respond to that support, are definitely referred to them. There is a waiting list for support with our IAP therapists, but we are trying to manage the waiting list to not to have 2-3 months of waiting time, to not exceed that.